Good afternoon and Assalamu alaikum. Welcome to today's ED's scientific seminar. I can see this corner still not taken up, but I can see some people up there. So maybe this is an effect of Ramadan, but let's all work to see the auditorium full to take the best, to make the best out of these seminars. Okay. And today we have a very interesting talk, a seminar, and that's on hospital sanitation system in Dhaka, Bangladesh, and implications for sanitation decision-making for healthcare settings. Very much on time, this topic. And today the speaker is none other than Nuhu Amin. Nuhu has been working relentlessly on water sanitation hygiene for a pretty long period of time. I just found out, well, I know him personally, but I just found out that he's a dental surgeon by training and by qualification. Surprising that we have a number of dental surgeons here who have gone back to work just on public health. And they are doing pretty well, like Nuhu Amin. So Nuhu also did a master's. He has an MPH. He joined as a research fellow, and that was when Steve Luby was the head of infectious diseases division. And since then, he has been working, all along. I think it was 2022 that we went to this CUGH meeting where Nuhu Amin received a very coveted award. So let's not wait, but to hear from him. And today, I'm very pleased that we have a guest who has joined online. And this is Ylva Schwim from SIDA, Swedish SIDA. And welcome and thank you for joining, Ylva. Nuhu, over to you.
Thank you, sir. Thank you very much. Assalamu alaikum, everyone, and happy Ramadan. So as sir introduced about my research career from 2010 to now, it's about like more than 13 years here at icddr and working on water sanitation, and I'm still sticking with that. And I think there is a huge opportunity in Bangladesh and Southeast Asia, particularly to improve the wash. I work on the urban wash particularly, but now focusing on more like wash in healthcare facility, because I found wash in healthcare facility is one of the difficult area that we are suffering to actually improve. Particularly the SDG is one of the biggest factor that we need to achieve by 2030. And there are a couple of loophole here that we actually didn't actually consider yet. And if we consider wash in healthcare facilities, like water, sanitation, hand hygiene, waste management, and environmental health are the components in wash in healthcare facilities. And when these actually also have very much cross linkage with each other, because if the water is not available, it impacts on sanitation, hygiene, and also like environmental cleaning. Similarly, if the sanitation in worse, then the pathogen exposure and IPC is actually compromised. Similarly, waste management, also one of the biggest component for the wash in healthcare facilities. And also, like you can see that there are, these three has very, like today I'm particularly will discuss about this. sanitation and actual waste management. When I will work on, like, talk on waste management, I will talk on the fecal sludge and liquid waste, because in Bangladesh, PRISM and government work on the solid waste management. I know there are some issues with that, but people have some idea how to manage that. But for the liquid waste, it's very much not actually like under researched around the globe. And also, like, why these are very important, because of like SDG 3 and 6, like good health and well-being and clean water and sanitation. So if we want to achieve this, so these needs to be actually at least at the basic or actually improve ladder. So let's talk about sanitation. And when we talk about sanitation, it's also a very much complex scenario here. It's a compromise, like comprised of a lot of like indicators and parameters. So first of all, if we tell that sanitation availability. So in healthcare settings, particularly if we talk about the large hospital has a like huge amount of patients flow all the time. And this has been actually compromised the toilet users ratio as well. And second thing is very important is also like functionality of the and the cleanliness of the toilet. So there are very lack of data around the globe, including the JMP, like global level and also like local level, the how the parameters for the healthcare facilities can be standardized for the clean, unclean toilet or the not usable toilet. So JMP has defined something with some the terminology, but due to lack of global data, has been actually very low evidence that what type of ladder actually around the globe is going on for this like functionality and the cleanliness. At the same time, lack of data on the toilet to users ratio, because this is one of the key driver for like availability, functionality, and the cleanliness of the toilet. Because if the toilet to users ratio are not actually maintained, this cleanliness and functionality also not maintained. So we did some work in during the COVID period, and we found that hospital having high toilet users ratio, but during the time, access to the toilet and the access to different department was restricted due to COVID-19, and we just actually like access to only 16% of the toilet. So this type of we are just replicating that things through this actually project as well. And like previous studies has been conducted only in sub-district level and not actually rigorously actually observing these parameters that maintained by like mentioned by JMP. If we consider outside of the hospital, what is going on, like hospital also produce a lot of wastewater, including the chemicals, like microorganisms, pharmaceuticals, and also like human excreta, body fluid as well. And this can be like fatal things for the environment if it is not treated well. And once it is actually coming out from the hospital, it's actually like mixing with our community, as well as like similar to the industrial effluent. And a recent study also, we found that children actually exposed with this wastewater and they got disease. And they ultimately, the hospital should be the center for the cure for the patient, but it is also contributing to disease, although there is no estimate how what type of disease estimated burden actually contributing by this hospital effluent. And we have some recent also, we published a lot of paper about the environmental contamination, about how our environment contaminated with the virus, pathogen, and also like other type of disease producing pathogens in the environment. So ultimately, we can say there are huge amount of like burden from like healthcare facility that's actually coming to our environment. So uh, today, we will talk about what is the current status of the sanitation facilities in major hospitals in Dhaka City, and what are the gaps that can be actually implementing, what are the gaps of the and the barriers of improving this sanitation ladder. So ultimate goal is to actually how can we improve the sanitation ladder based on the JMP, and how can we achieve the SDG by 2030. Let's talk about the methodology very briefly. Here, you can see at the right side of the picture, the distribution of the hospitals and the different dots actually highlighting the distribution. And the next slide, I will discuss about the selection of the toilet hospitals as well. So we selected 10 government hospitals and 3 private hospitals based on some selection criteria. And it was a cross-sectional mixed method study. So it contained both observations, qualitative interviews, and also like infrastructure assessment. and some mapping as well. At the same time, we collected this information at the real time using the Kobo toolbox. And this is the flowchart. It's a little bit smaller, but just to let you know that uh, in Dhaka City, there are about 22 government hospitals. Among them, we try to categorize them in general medical college hospital and also a specialized hospital. And among them, we try to like select the hospital that represent that type of category of the hospitals here. So you can see that we selected all type of hospitals from different ladders. So generally specialized and also like medical college and hospital. From the private hospital, we selected only three hospitals for the uh, three hospitals for the quantity or the observation, but we did not actually get approval from one hospital, so we dropped from them. So ultimately, for like observation, we have two private hospital, but for the environmental assessment, we have three hospitals here. And approvals was one of the critical things here because hospital working in the hospital is a little bit difficult because it's has some issues with like government priorities and other issues. So we obtained a lot of approval from particularly the DGHS and also like ICDB ethical clearance. We also got like University Technology Sydney, who is our partner for this project, and for the qualitative interviews, we got consent from everyone that we actually included in this study. For the data collection approach, we collected information from the nurse and ward master. So why we have collected like this? Because we have like wash cell in hospitals, but wash cell usually don't have the updated data collection or updated information in their repository. So that's why we went every ward separately and asked question about how many patient actually staying today and what number of toilet in this floor and who actually using which toilet, whether it's used by staff or used by like caregiver or like used by other people as well. So we collected separate data from different type of ladder from both hospital repository, like local repository, not like central repository, local repository. And then we asked the nurse or the ward master about the current status of the hospital and who are using what. This slide is very important for to understand the method because this is how we have like uniquely actually this is the uniqueness of this study that we have incorporated and how we are very confident that we have collected very authentic data for the JMP so that we can use it for the future replication as well. So we used actually like census of the toilet. First of all, like we included all toilets because why we included this, because we found that we try to sample first of all in during our initial stage, but found that different hospital has different type of structure. So for example, if you could consider the Kurmitola General Hospital or Kuwait Mitri Hospital, they have a structure. But if you go to the cancer hospital, they have different buildings. So sampling of the toilet is very difficult and the wards are not very much well organized most of the time. So we actually do all that, observe all the toilet, and also we ask included all the person who actually come to the uh, healthcare facility for the treatment or anything. So we define the user as any individual present at the hospital on the day of data collection and who might expected to desire to use the toilet during their stay at the hospital. And also the toilet block is like we use the cluster or block wise like toilet estimation and user estimation because there is a spillover chance of patient actually using different toilets. So we ask the predominant user of certain blocks or certain toilets here. So toilet blocks are actually defined as a single toilets or a group of toilets within healthcare facilities that were used by specific and defined group of people. So let's go through this diagram because understanding the toilet block is very critical for this study. Otherwise, the result will not be actually will not difficult for understanding. For example, in this diagram, you can see that there are 4 toilets in this layout of this hospital, like one floor of the hospital. For example, if you consider this as one of the like observation of a medicine ward, then it's a patient sitting area. Then this is one staff toilet area or staff waiting, like working area. This is medical store or administrative or any other area. So these four toilets used by different types of people. So if we consider that for this first toilet here, this is actually used by only patients. Then we actually define this toilet as toilet for patients and their caregivers. So because these toilets they have reported exclusively used by patients and their caregiver. For the second block, for this area is used by, if it is used by mixed user, for example, patients and also like staff, then this is actually considered as like shared toilet, shared by staff and also like patients. And for if the toilet is used exclusively by the staff, then it will considered as a staff toilet. And for example, if it is also like used by the admin people or like store or other things, then it is considered as toilet blocks for staff as well. So we have, if it is used by one professor or one director, that is also a block. And we consider number of block for that toilet. Each cabin was also a separate block. Why we consider? Because each block has separate users and we have to count every users according to the block. So total category would be for this toilet user is patient toilet and their caregivers, staff toilet, shared or like gender segregated toilet, like male, female, and mixed toilet. And also we recorded the disabled friendly toilet as well. So now I will go through a little bit about the definitions of the parameters that what we have what we do mean by like functionality and how we collected the data and cleanliness. So functionality, when we say functionality, it is called like whether the toilet pan or commode is functional or not, whether the door lock is like functional or not, and making the privacy, maintain the privacy. The like what are the currently used as, because we saw a lot of toilet is used as a storeroom. So this is also another parameter we have added in the questionnaire. At the same time, that whether the water is available or not. So these are ladders is also like aligned with the JMP wash in healthcare facilities as well. For the cleanliness, we have used like there is no actually data on how the healthcare facility toilet cleanliness actually assisted. So we use the another tool that community-led cleanliness they have assisted recently in Africa particularly, and they have like cleanliness of the pan, cleanliness of the floor or toilets and smell. We also recorded like solid waste within the toilet and any spider net within the toilet. So we also smell, and smell of feces is also one of the indicator for the cleanliness. And these are the some Likert scale we also use for understand the level of cleanliness, like not dirty at all to actually not usable. There are 6 ladders, so we just divided it for like 4 ladders to make it understand clearly. And this was, as I said earlier, this toilet to users ratio is one of the biggest factor for this reason. So you can see that the queue in the outdoor and the queue in the inpatient and also like extra patient, extra bed in there. So when we plan for like policy or for like wash in healthcare facility, we mostly overlook this type of scenario. We all the Bangladesh government parameters is also like describing on like number of beds and their facility, toilet facility, which is not actually, I would not say this will achieve the goal, because it's not about the number of bed, but number of people or users we have to consider. So number of toilet user for, we collected from the register first of all, then number of patients stay during the day of data collection from each block, and number of caregiver reported by staff or not, because in ICU caregiver will be different, in medicine ward caregiver will be different, and in OT and post-operative caregiver will be different. So that's why we have collected caregiver separately. So that's why we have actually authentic data from this for this study. And secondly, we also collected information about the sanitation, like wastewater treatment strategy of this hospital, because we know everything is going to the drain and mixing with our community drain, and we are exposed with that. And so we try to understand the functionality on of the septic tank or anaerobic baffled reactor. So just for example, here you can say this is one of the hospital where their red marking mean it's actually everything is going to the environment. So there is no containment, there is no septic tank or actually broken septic tank. Another example from this right hand side, you can see that the this is the hospital drainage system that around the hospital is going on, and this is one of the septic tank or ABR, like 8-chamber anaerobic baffle reactor, like treatment option for the fecal sludge. And if it is functional, then it is actually marked as a green, so that it's like discharging predominantly safe, and we mark them as a safely managed sanitation on that of that facility. But here you can see another like point where it's like directly connected with the drain. So although they have septic tank or ABR discharging functional well, but if there is any like bypass channel, it is also considered as like not safely managed sanitation facility. So we have all this mapping for all 13 hospitals, but some due to some lacking, we couldn't actually manage it. Very briefly on the qualitative, I'm not going very detail on the qualitative data because it's also another thing. So we collected about 39 interviews, and among 39 interviews, 7 were from the uh, PWD, Public Works Department's engineers. So they are usually responsible for construction and maintenance of the sanitation facilities. Uh, 13 from the ward master. They are some kind of bridge between like hospital authority and the PWD. Also, we collected information from the cleaners that what type of issues are actually going on, why the toilets are not clean most of the time. Also, the user's perspective, we also asked some question. So we mostly we done some descriptive analysis of toilet users ratio and number of frequency of functionality, frequency of cleanliness. We also did some like univariate and multivariate analysis to understand what are the reasons for these unclean toilet, what the factors actually uh, contributing the unclean and non-functional toilet. I will talk this on during the results section. We followed the standard procedure to analyze the qualitative interviews, and I'm not going to detail on these things as well. So let's come to the results here. So you can see it's like huge task, about 3,000, like 2,800 toilets. We observe everything of the toilet in these like 13 hospitals. And highest toilet was found in more than this 318, 430 toilets actually in one hospital, followed by another hospital, 379. And lowest number of toilets was found in hospital 8, 43 toilets. And you can see the government hospitals are actually marked as H1 to H10. And the private hospital is like marked as P1 and P2. And we are successful at like covering like access to the toilet. 86% toilet were able to observe. Rest of the 14% we couldn't observe because of like it was locked most of the time, and like access was not permitted. This is the results on the functionality. So only less than 70% toilets are functional. So with this extreme overloading, 30% toilet was actually not functional. And we also know the exact causes of the non-functional, like about 10% is the non-usable toilet, but the rest of them are very easily repaired. Like if you just like repair the locks, or if you just repair the like some leakage or water pipes, it will get functional. Rest next 35 toilets we found is clean. So huge number of toilets we found as unclean, and this could be one of the source of infection spread from the toilet to the hospital environment. So all you can see also all the toilets hospital has also similar type of like non-functionality, huge number of private hospital has little little improve compared to the toilet from the government hospitals. And toilet to users ratio, this is the government recommendation, is 6 bed, 1 toilet for 6 bed, which I think needs to be revised because current like water aid recommendation is 20 to 25 users. Current wash fit actually recommended 1 toilet for every 30 patients or 30 users. So we also considered the users as like for Bangladesh, the patient and their caregivers as well. For for the like staff, you can see the toilet to users ratio here. It's actually underused most of the time. So it should be like 1:30, but here you can see the toilet users is very less than actually 10 most of the time. But if you consider the patient, you can see the toilet users is way high all the time for all the hospitals. And in one hospital, we found one toilet is used by more than 900 users, which is actually is like more than a public toilet. So this needs to be actually documented and needs to be taken care of. And if we go down further, actually detailed analysis of the like toilet users from different department. So we also said that inpatient service, the toilet to users ratio are pretty good. Like it's within the range less than 20 or within 20. But in the outpatient service, all the general medical and like specialized hospital, all are very like way above the like limit. So also you can see this like staff toilet is always been low ratio. So staff toilet are mostly underused. Like space of the hospital is underused by the staff toilet. But private hospital is predominantly like lower ratio, but still staff toilet is has like patient has a higher proportion of toilet to users ratio. Uh, if we if we see it with the gender lens, like how the gender actually use. So overall, it looks like genders as like a similar type of non-functional or functional toilet. Like all are 70% of the functional, and it looks like very similar. But I can just highlight here that mixed user toilet that used by both patients and like uh, uh, patients and staff. These are actually least like functional compared to the other toilet. And also the toilets from the outpatient service are also low number of functionality we have found. Similarly, the cleanliness, you can see that the cleanliness of the toilet is also for the mixed user is very low compared to the other toilets. And cleanliness of the male toilet was also less compared to the female toilets as well. Let's talk about a little bit the like regression or like what are the causes of this, maybe possible causes for this unclean toilet. So factors influencing like general hospital or private government hospital versus private hospital. You can see that private hospital has like more functional and more clean toilet compared to the like private government hospital. Uh, Hospital constructed after 2000, year 2000. That means if the hospital is actually, the building is new, their functionality and cleanliness is new, better compared to the like older building. Uh, Staff toilet is always been like clean compared to the patient toilet. So this is also very usual because they maintain it by their own janitor. Uh, Detailed dedicated separated toilet that is also cleaner compared to the like mixed user toilet or mixed gender toilet. So just to highlight this hand washing issue, because I think this is also one of the important indicator. Good thing is like about 90% of the hospital in Dhaka city has water, so which is very good. But the basin was 75% hand washing facility was like active or like functional. The problem is with the soap availability. So soap availability was like less than 20% most of the time. And if we segregate this by patient and staff, this number will also like reduce. So we can introduce like very simple soapy water dispenser in this hospital to improve the access to like hand washing. And this can be actually improve the hand washing later. Then hospital and MHM, menstrual hygiene practice and hospital is also absent. I would say it's not like low, it's absent. So that's why you can say only 18 hospital, we found 18 toilets. We have only been, but there is no facility for MHM service. So we can actually propose this like bin for every women toilet for the MHM disposal, safe disposal. And also like we can actually like ensure the availability of the menstrual pad. There is available technology in our country that actually now marketing by different companies. We can also utilize this. Similar things like disabled friendly toilet is also absent. Like That's why we have, with the simple intervention, we can actually improve the JMP ladder and improve the service quality in the healthcare facilities. And wastewater is another very big area, but I'm just summarizing this in one slide because you can see among these 13 hospitals, both private and uh, government hospital, these four only, like red highlighted, had no like wastewater treatment strategy in our country, in Dhaka city. So everything is going directly to the then whatever is producing within the hospital, in the laboratory, in the radiology, in the antibiotic areas, patient excreta, everything is going. Three has partial, like some broken or some like non-functional ABR or septic tank. Rest six has some sort of actually like wastewater treatment strategy. So that's why there is very urgent need to actually install on-site wastewater treatment strategy for hospital. Otherwise, our environment is like polluting through this healthcare facility very badly nowadays. Very briefly on the qualitative, so cleaner actually mentioned about lack of cleaning stuff. So this is frequently actually they are mentioning these things. Multitasking, the cleaner says they are not only cleaning the areas, but also like hearing about the doctors, they have to serve the patient sometime, clean the patient bed, like bring the food for the patient. So there are lots of other tasks they also do. Then frustrated with the job responsibility, and there are so on so there are lots of issues just needs to actually address for the cleaning, improve the safety as well for the cleaning as well. Ward master, which are like bridge between the engineers and the health authorities, they also actually address that there is a lack of cleaning stuff there, and also like lack of knowledge of the users. They blame the users that they are not able to use the toilet. So after eating, they actually throw everything to the toilet and toilet get blocks. So that's the problem. Actually, they cannot adjust, and it's a frequently problem. And no fund allocation for the wastewater treatment facility, so they are not aware about what is going on outside of the toilet. They are not seeing. Similarly, PWD engineer said that high pressure flow is one of the biggest problem. Older buildings is not suitable for this type of maintenance. So if we want to address the JMP ladder, we have to actually change the infrastructure. So engineering infrastructural innovation is very important for future actually studies to integrate in this model. Patients is also like addressing that. They agreed that patients has limited amount of knowledge about how to use the sanitation facilities. They agreed on this, and they said that MHM facilities and other, there is nothing in the hospital, and they address it. So we have a lot of like 39 interviews, so I'm not going to all of this. So if anyone interested, I'm happy to share. So I have already done, but few slide I'm only to understand like what should be our, like what is our next goal and what are we are going to do. So we already submitted, published one like global low income settings wastewater treatment strategy and how they are functioning. And also this is the paper we have submitted to, it's under second review right now. We have also like to overcome the gap I have shown you, that hospital IPC and like wash in healthcare facility improvement. We also submitted a grant recently to the integrated health science research in recently. So I think we partner this time with PWD because PWD is very bureaucratic and they're very difficult to actually reach. So we partner both DPH and PWD along with like Ministry of Health. So also we already awarded one of the project, you may, some of you know, this hospital wastewater treatment plant in Kuwait Maitre Hospital. So this is one of the groundbreaking study. Hopefully we'll actually install this in April or May. And this, if we success with this model, hopefully this can be replicated in other studies, other hospitals as well. And we have some actually stakeholders engagement with these projects, and we have vendor already selected and is fabricating, and this is the current work we are going on. And this project has been successful because of these people. Actually, Imam Hossein is actually present here. He worked really hard. Like Samia Sabur and our field staff, Jamil, and they worked really hard for this project day and night for these things. And that's it from my side. And thank you very much. Over to you, sir.
Fascinating, Noho. really. I mean, you have walked us through uh, very practical things, you know. This is real health systems, okay? 3,000 toilets, 30% only functional, you know, that's the
Yeah,
story, you know.
yeah.
So let's have questions for Nuhu. But before I give, we have here somebody who has managed large hospitals in the country very successfully, Dr. Fazlul Kabir. I don't want to put you on this spot, but I just want to start how efficiently you managed two large hospitals in the country. What we saw here, you know, one of the slide you have seen that Nuhu uh, showed, the the things that came out from the cleaners as well as from the ward masters. And the cleaners, they say that they have multitasking. Although they are cleaners, they have to be busy with, you know, bringing food, this and that. But we know that the government spends a lot on, you know, for these cleaners and other staff. What do you think is the problem? Is it something that we can do by tightening the governance, or is there additional resources that have to be spent?
Thank you, Thamil. You have correctly pointed out, is the problem with the governance. Is the governance. The resources are abundant and it's not properly managed. That is the problem. So, because they have all those so-called the organizations, the employees, and they try to occupy the chairs and they don't do any work. So there are, say, 500 cleaners, 200 are the managing the society, 300 are workers. And those 200, their work is being shared by these 300 additional. So that is the problem. So if the hospital manager can effectively control that organizations, those are basically legal, authorized, but the way they, I mean, use that, because there are a lot of money involved in it. The leasing of the shops. Yeah, he was with me also in Kumudala Hospital.
One of the hospitals, sir, actually was there. Yeah.
My hospital was also there.
I didn't disclose any name of the hospital. Yeah. Because we took the consent according that we will not disclose to anyone which hospital is what.
So in Mamashing, it was a big problem, but in Kumudala, it is not that big one. So what I did in Mamashing to nullify the organizational political phase with the help of the local politicians, the leaders, that they will do their work at their own, and I will allow them after the office work. During the office work, the office will remain under lock and key. The organizational office will remain under lock and key. The shops will be given to the vendors, I mean, those who gets it, and so and so. So that's how the workforce was bound to be on the board, and the fingerprint and attendance supervisors are made function. That's how these are managed.
I hope that the system that you installed is still in place, you know, keeping the trade union offices closed during working hours. But thank you very much. Sattar?
Yes. Thank you, Nuvai. It's a nice presentation. So I have two questions specifically. One is, does the respective hospitals know their own situation, the hierarchy, the higher administration? If they don't know, so do you have any plan to inform them? Because you have you're showing that data anonymously, not disclosing anything. So what is your plan to share your findings? Then they can take some initiatives to improve their condition.
Yeah, we have that plan because we have actually final result and also going to publish. So with this publication, we will prepare a full report of all hospital, like all we have also like segregated data of all hospitals, all ladders. So we'll prepare a book type of things and we will distribute this in 13 hospitals and we'll tag the respective hospital that this is your hospital and you can do whatever you like. So we have that plan, yeah.
So we have another guest who has joined online, and he is Mr. Mashkur Reza, and he is the head of business development at Eastern Bank Limited. And I want to thank Mr. Reza for joining online. And I want to tell you that EBL has been supporting us with a substantial grant, and this is also related to waste disposal and management. So this is a very good project, and I am sure that the outcome will be good, which will not just help us, ICDDRB. We spent a lot of money. Every month we spend more than $6,000 just for, disposing some medical wastes. So this cost will come down, and I think the results will also allow other institutes in the country to, follow same. So thank you, Mr. Reza. Appa, you wanted to? Okay, yeah. Yes, it's a long way to go, but the work has started, and inshallah, we'll be able to achieve that. You wanted to? Yeah.
Thank you so much, Nu. This is a problem not only in hospitals, but I think all over Bangladesh. When I'm traveling out of ICTDRB, out of my home, my first concern is that I don't have to go to a toilet. I think that's how bad it is. I mean, even in the universities, offices, anywhere. I think especially for women, I don't know about men, but for women,
Exactly.
it cannot be accepted all our lives. I think this messaging is not only for hospitals. It should be some way that we can take this up. When we have the toilets that we have, I don't know how many, each of us in our sections actually control the toilets by seeing that it's clean. Sarah takes one, she takes one, I come round. We all see that it's kept clean, our women toilets. It's not only the cleaners, it's how we use it. I think it's a big responsibility. I think this should be disseminated.
Appa, I think I just want to add with Appa that I shared some of the content of wastewater treatment plant in the social media, and many people ask, what about the ICDDRB? You are also like generating a lot of feces and also like lab reagent. Do you have this type of things? So I think we are also planning for that. Hopefully we'll also work on that. Yeah.
That's also a long work. We did a lot of research, and that was in the year 2016. Lutfe, I'm not sure if she is here. So Lutfe and then many colleagues in the hospital, they did it. And that has been done very scientifically, following certain WHO specifications. But we need to work on that more and see how we can further fine-tune and optimize things. So this is a work in progress. But I want to tell you one thing. When I was the hospital administrator, I used to go to the toilets downstairs, okay? And I can tell you that the toilets that we have downstairs, I'm sure that this is the same now, very clean. What does this tell us? This tells us that it is governance issue that is most important. What Dr. Kabir just mentioned, if there is good governance at the lower level, you can expect good functional toilets. Otherwise, it's going to remain the same. What we just heard from him is that the government of Bangladesh spends a lot of money, but still then, we have staff who are not well monitored or supervised, and that's why we have all these kind of things. In the Cardiovascular Institute Hospital, we hear many stories about what happens when you don't have proper toilets there. So I think, Nuhu, it will be great if we can find out a way. I mean, this is not new, okay? What
This
we
is
have
not new,
found
yes,
out
sir. Yeah,
is
this
not
is not
new.
new, yeah.
People know about it. All of us, we know about it. But the very systematically way that you have studied it, this is evidence.
Yes, sir.
And now you need to place it before the policymakers. So think about how we can talk about it either to the Director General of Health Services or to the Secretary Ministry of Health. But I think we should also try to talk to the leaders of the fourth class employees. There are, isn't it? They can, I think they can help by doing something. I don't
Yes,
know
sir.
what it is like, but think about that. Maybe I can also help you
Yes,
in
sir.
this regard.
Yes, sir. Yeah, we are planning also to make some documents, sir, about the policy. After this publication is
Very
released,
good.
hopefully we will do some dissemination as well.
Very good.
Because both of the study, like this hospital sanitation and this wastewater treatment, is aligned. So the DGHS is also our partner for this project, and they also co-author in this project. So they know about the situation. So we are working on that with them as well, yeah. But there is a gap between the PWD also. Like PWD is very critical because, so we are also trying to understand their motive on this, yeah.
It is very good that you have engaged with them as a collaborator.
Yeah, yeah.
In one of the grant applications.
Yeah,
That's
yes,
a very
yeah.
good step. Any final questions for Nuhu Amin? Munir Bhai.
Thank you for this wonderful presentation. So this is not, I don't know if it is a question or just comment, like, I myself organized a town hall meeting for how to use the toilet in ICDDRB in this hall. I don't know if any of you are still, aware of. Because when I came to ICDDRB, I saw that the toilets are not being used properly. This is basically by the, newcomers or maybe of the, people like, support staffs and others. And I felt that actually it is needed. And also, when I saw that the entrance of the ICDRB hospital, just beginning from the public health, department, that there were like, stream of like, body fluid moving. So I met with the director of the, IPH. And I talked to him and he called someone, and then his staffs just argued with us saying that, like, some of the low level, employees, they are involved in like some business by allowing some makeshift, uh, restaurants and other things. And that allows the, this kind of thing. So, rightly, it has been pointed by APA and Tamil by that, like, there should not be shade under the light. Like in ICDRB, we should also be responsible, each of us, to make sure that the toilet that I am using, if I make sure that the toilet is usable by the next person. So sometimes we see toilet is in such a state that you cannot eat food, after that. So unfortunately, so if every one of us, we do this, I think it will be ultimately, it will be clean toilet as mentioned by Taiwan Bhai. Thank you.
Thank you, sir. Thank you for
No,
valuable
thank you. Very important. And again, the way Kadri Appa, Armana, and others, they are trying to oversee the, toilet cleanliness. I think it's all our responsibility. If we see that things are wrong, we have this unit, and they are ready to help. Just let's tell them that, look, place somebody there. Let this thing be cleaned. So it's all our, joint responsibility, sir.
Thank you, no. It's very interesting and it's eye-opening for this. But I have one small query. One is, did you consider the outpatient department of big hospital, like say BSMMU? In a day, there are about 7,000 to 10,000 outpatients. In DMC, similar numbers. In Medford Hospital, similar numbers. Did you consider the outpatient department toilet facilities and uses and the numbers there and the adequacy? In inpatient, number of toilets seems like reasonable, but But during the planning, probably they consider bed, not the number of people using. Like for each bed, there are 2, 3 people attending at some point in
Yes,
time.
sir. All right.
So this is one point. Secondly, can you consider next time the sanitation facility in the schools? I tell you one example of my personal experience. My grandson used to study in the government laboratory hospital in from class 3 to SSC. And what he used to do, he did not use toilet during this time. School timing, he did not use. He used to rush for home. Thank you.
Thank you, sir, for your valuable comment. Yeah, we segregated the toilet users by inpatient and outpatients as well. And in inpatient, as I showed you, like about 20 users, which is managed fine. But for the outpatients is like 200 plus all the time. So that's the biggest challenge for the outpatient. So if we want to improve the outpatient service, then we have to increase the facility. And if you increase the facility, there is very lack of space. So we have to be very creative on engineering solution, not behavioral, not other things. It should be infrastructural changes. Yeah. The question. Okay, please go ahead. No problem.
Yes.
Write it down. Okay.
Write it down.
Acha, did you explore the total and
No.
toilet and wash using
Instructions.
instructions? Using instruction, any correlations
Yeah, any
Cor-
correlation
with
with
cleanliness?
the cleanliness.
Okay.
Any, yeah, observation of instruction that.
I got your
use
point.
This and any, because this will affect the SBCC. I think so.
I got your point. Yeah, you can see we didn't find any sign for the toilet user, and you can imagine that user's instruction because there is no sign for male or female toilet. So there was no instruction actually for the toilet cleaning or user perspective. Yeah.
Hello, sorry. Bhaiya, so I had this one comment. Actually, I'm from university, like Asian University of Women, where only we girls get the education. So we had these vending machines in our university, like 2 vending machines of menstrual hygiene management for menstrual sanitation pad. And the other day I was talking to my supervisor and we were discussing what if we had this vending machines in the women's toilet in ICDDRB as well. And now today, like seeing this listed in your intervention, it just made me happy. Yeah, I
Thank you
just
so
wanted to
much.
share that.
Yeah, that's very important, I think. And I think Sir and other people actually listening. So hopefully it will be implemented sometime. Yeah.
Okay, so it's just a few minutes to 3. No, thank you very much
Thank you, sir.
for those of you who are young, I would like you to, take note of the presentation. See how he has presented, okay? It's like a story. And look at the slides, very wonderfully, very nicely, prepared, not doing something over, not over dramatizing, but, placing the facts as they are. This is what a good presentation should be like. And I would like all our younger colleagues to take note of that. Okay. And Nuhu, once again, thank you
so
very
much, sir.
much.
Thank you for your patient hearing. Thank you very much.